towards the end, right, with political complexity in the debate. Allow me at the outset to extend my sincerest thanks to all and sponsors, study the Global Center for Health Equality and Inclusion for convening this vital conversation. SRHRJ's steadfast commitment to promoting inclusive, rights-based health systems is deeply appreciated, and your work continues to provide much needed bridge between global policy dialogue and tactical action on the ground. We meet today at a complex and challenging time, as you all know. Across the world, we are witnessing the rise of anti-rights narratives and regressive policies that threaten to erode decades of hard-earned gains in health, gender equality, and human rights. The right to health, enshrined in international law and reaffirmed in the Sustainable Development Goals, remains unevenly realized and too often politically contested. And I cannot overly emphasize, as I'm sure we're all aware in this world which we live, that many of those rights enshrined in international law are under direct attack. The laws themselves have been eroded, and if there were ever a time for us to come together to hold on to what is there to protect and to use the opportunity before someone else, every crisis is a wonderful opportunity to make more gains. This would be it. For women and girls, particularly for those in vulnerable and marginalized communities, what is going on today has real protection or adequate resources. The right to health becomes an aspiration rather than the lived reality that is everyone's share. In the Caribbean communities from which I come, we recognize that operationalizing the right to health demands more than commitments on paper. It requires systems, partnerships, and accountability. Through our regional strategies and multilateral cooperation on universal health coverage, gender equality, and adolescent and sexual health, CARICOM member states are working collectively to translate rights into action and principles into practice. We are investing in integrated primary health care, gender-responsive budgeting, and data systems that make inequity visible and actionable. We are advancing health diplomacy to tools of small island states to shape global health governance and ensure that the Caribbean voice is heard at every level. But we know this journey cannot be walked alone. The right to health is universal precisely because it depends on shared commitment and collective responsibility. Whether through partnerships between agencies, civil society, academia, or international development partners, or tasks is to build a global movement that safeguards its right for all, especially at a time when it is so understood. This means putting people at the center of all we do, recognizing that health is not a privilege, it's a foundation of human dignity and sustainable development. It calls on us to ensure that every woman can give birth safely, that every adolescent has access to information care they need, and that every person, regardless of gender, income, or geography, can live a healthy life. As we engage in today's discussion, let us be bold in our vision and practical in our strategy. Let us reaffirm that health, equity, and rights are inseparable, and that our collective responsibility is to make them real for every community we serve. I thank you once again for this opportunity to join me, and I look forward to the outcomes of this very important battle. So, if I can turn now to our first panel, Dr. Heidi Getty-Boone, the founder and CEO of SRHRJ. Dr. Getty-Boone, when we talk about the right to health, what exactly do we mean by this? What are the obligations and entitlements, and do they extend to sexual and reproductive health?
Thank you, Alison, and good morning. Yeah, so the right to health is a convention, it's obligation, it's commitment, and it was enshrined in several laws, international laws, and the main one being the Covenant on the Economic, Social, and Cultural Rights, which actually is signed as state party by 174 countries, which entails this commitment and obligation by the government. Number one, to respect that government will not interfere in any way in the enjoyment of the right to health of their citizens. And the second one is to protect that government will also committed and obliged to make sure that third parties will not bring any harm into the enjoyment of the right to health. And the last one is to fulfill that governments should place everything needed from administrative, financial systems to ensure that this right to health is enjoyed by every citizen in their country. And the right to health is why that's why we are saying the right to health is a gateway to universal health coverage. Universal health coverage that includes every service and every need of anyone without gender and without any discrimination. And sexual and reproductive and gender rights are included, and the covenant of the cultural, the economic, social, and cultural covenant actually explicitly stated that the rights, the sexual and reproductive rights are an integral part of that right. And also we have so many other international obligations that further emphasize the right-based approach for the sexual and reproductive rights. One is the convention, the covenant on against the women, against the women exploitation, and which actually clearly stated that women should have equal rights like men in order to have access to the right to health, including pregnancy and postnatal and lactation. Activities are explicitly mentioned, which actually differentiate the woman from the man. So this covenant against discrimination against women further entails this important activity. So that's why, especially now, when global order is under attack, that we have to go back to the basics of reminding our government that they have signed to this integral obligation to make sure that their citizens have the right to health, to enjoy, and also to live with absolute health and well-being.
Thank you very much, Riley. I'd like now to turn to Dr. Ana Luisa Caldas, Secretary of Primary Health Care in the Ministry of Health of Brazil. Dr. Ana, Brazil has made great strides towards achieving universal health coverage through primary health care and community-based approaches. What, in your view, are some of the best practices that governments can apply for a rights-based approach to health care that reaches every person and includes essential sexual and reproductive health rights services? Dr.
Bom, when I'm speaking in the party, então bom dia a todos e todas que estão nos assistindo. Agradecer por estar. Can you translate for English? When I'm speaking in party, Brazil.
El portugués al inglés. Ok.
Ok?
Yeah.
Bom, agradecer e dizer que eu acho esse espaço, como já estamos aqui, já mostra um grande avanço nas políticas de equidade de gênero, olhando para essa mesa, né? Esse doutorado está aí moderando e temos a maioria feminina. Então, isso já demonstra,
Está saliendo en portugués, no está saliendo en inglés.
it's not translated.
Yeah. En inglés, sí, sí.
I can try in English, but it's not that good, but I can. Well, bem, então eu queria agradecer, né, que a gente está trazendo como pauta a experiência. Not that something. You did something that. Okay. Can you move to the next panel? Okay.
So we'll come back to Dr. Anna. If I may then move on to my next panelist, Ms. Aisha Amin, a youth advocate and founder of VITAC, Challenging Taboo in Pakistan. Ms. Amin, in your experience, how does the right to health fit in as a framework or tool for improving access to ethical outcomes for marginalized communities, including youth? Hi, everyone. I think it's a very important question. And when I look at rights for exposures and living marginalized communities, it still feels very distinct because that's how far away we are.
the Portuguese to translate to English.
Like why is five
We're trying something.
life is crucial for everyone, especially for members and women in those communities. Why is it not a priority here? And I think it's because it is not just a health issue, but also a sexuality and gender issue. Because when there's lack of access to SRHR or when SRHR is not integrated as a right to health, or it is research coverage, or is a priority, it takes a toll, like the most toll is on the body of vulnerable and those are the voices that are missing in the
Recognized
cases,
Portuguese,
right?
you
So
know,
very patriotic and very-
English. Yeah. Okay, good. Okay.
I also want to bring a bit of context into what it looks like when SRHR is not entered as right to health for those communities, especially for communities that are affected by climate disasters. Because when we talk about marginalized communities, we see that grassroots communities, rural communities are mostly impacted by are very the brunt of climate disasters, whereas they're not really causing it. So SRHR has not entered into those frameworks, into those policy discussions, into those priority areas. It means that when health facilities are washed away in floods, women are forced to give birth in very unsafe conditions, in just emergency rooms, which is a very serious enforcement upon their dignity about their safety and health. Adolescent girls are forced to cancel menstruation without any access to facilities.
But I'm changing the language to recognize the Portuguese, so I have to end the session and put all.
And that's the cost of not having integrated into priorities, right? And then we ask that how can this ensure equitable, access, for marginalized communities? I want to share a bit of, work that we have and how we ensure that this is seen as a priority. So, a bit more context. The word breakfast actually, the Urdu word, it means gathering or sitting of people. So this could be a breakfast breakfast, right? So one of the core ways that we do it is by
the missing voices are women, young girls from those communities. So spaces, those buttocks, where young girls and women can come together and not just become passive recipient of information, but actually have resources and spaces to reflect, to ask questions about their bodily autonomy, about their maternal health, about their reproductive health, about their sexual health, and question why this is being taken for granted, why it's underfunded, why it's not prioritized. So, first, creating those spaces where young girls and women from those marginalized, from those climate affected communities can ask questions, can demand, and then the second step is enabling their leadership to actually hold their local governments accountable, which we do through a very powerful and amazing initiative that we call Behenchara Collective, which translates into Sisterhood Collective. This is a network of 25 young feminist activists from those communities who are building those spaces for other women in their communities, but also holding their governments accountable. So every time a disaster hits, these women go and demand SRHR as a non negotiable, demand that pregnant women have access to maternal care, that they have access to safe delivery, that adolescent girls have access to wash facilities, that women have access to dignity and safety in those flood camps. The third component is male engagement that I really want to emphasize on, because as I mentioned that right now the decision making around women's bodies and bodily autonomy in SRHR is being done by men. And this is one of the reasons why this is not prioritized anywhere, right? And so changing those mindsets around male engagement, around masculinities, um, enabling men to become allies for creating spaces for women in decision makings, because men cannot make decisions for women's health, right? We need more women, but we also need men to create those spaces at local level, at national level, at global advocacy spaces. So these are some ways how right to health, especially SRHR as right to health, can empower and enable young girls and women in marginalized rural communities to ensure that they have safety, dignity, and health, and are also treated as humans.
Thank you very much, Aisha. Great response. And turning now to my last panelist for this morning, Ms. Betty Herlina, an Indonesian independent journalist and founder of Bincang Perempuan. I hope I didn't mangle that too much, Betty. Um, Betty, how can media elevate SRHR and maternal health issues as fundamental rights, especially in this time of a growing anti-right narrative on this?
Okay, thank you. Morning, everyone. Yesterday, when I arrived this Agora Center, I walk around in the booth in the exhibition. I'm asking participant there, how is media in your country help you support you campaign about your work? And most of them said some media help and another media help. The situation is almost same like Indonesia in my country, because not all media interesting to cover this issue, because this issue not really interactive, not get more audience. They cannot get a lot of audience from this issue. This is we are independent media, Bincang Perempuan, and with another with eight independent media in Indonesia, we call that Women News Network. We work together, take the role, take the position to promote this issue. Why we need to promote this issue, and what should we do to promote this issue? As a journalist with 17 years experience, I'm not the best one. Maybe in this room, there's any other journalist with their own perspective. We can share together. I just share my own tips. Okay, sorry if it's a little bit different with your work, guys. What I did, when you cover this issue, you need to think about, this is about human right and public healthy issue. Just 2 points. Don't thinking about is it a morality. Don't thinking about is it political, because when you thinking about is it morality and political, it will make your reporting is biased. For the example, in my country, Indonesia, we cannot talking about sexual education. Yesterday, I got this condom. It is first condom in my life. I got it. Really? in Indonesia, we cannot do like this. Yeah, because there's a lot of prohibited when we share this. When I give this in public, people would say, "Oh, Betty is a liberal. Betty too liberal. Even she's wearing hijab. Betty is feminist. She tried to campaign about, come on, we can do free sex together, just like that." Is it stigmatized, and is it a bias? We need to break it, right? So the most important thing when you create the reporting, you must first, this is a public issue, public health issue, and it is about human right. Don't thinking about religion. Don't thinking about is it political. In Indonesia, because we cannot talking about sexual education. We cannot teaching children at the junior high school, maybe at elementary also. But the fact there's a lot of sexual harassment, especially in school with religion. We call that pesantren. And most of the perpetrator is ulama, our religious leaders. Yeah, this is the fact. And I feel so sad to tell about this, but it's, yeah, we're still fighting for this. And the third tip, you should put the data. You should put the data, and you to break the bias to, because there's a lot of misinformation and disinformation when you create reporting about this. When you try to reporting about you cannot drink sodas when you getting period. So what should you do as a journalist? You should put the data why we cannot drink a soda. And also you cannot put the title. I mean, like if you found someone or maybe a couple of teenagers and they are pregnancy because they have relationship, you cannot put, oh, there's any teenagers and they should get a punish because they having sex before married. Don't put the title of your story like that. Better you should put the teenagers have right to get information about sexual education, about their own body. And other case, maybe if you found someone woman, okay, 1 minute more. If you found some a woman unwanted pregnancy, because in Indonesia abortion is prohibited, don't avoid them. You should create other angle, like a woman with unwanted pregnancy have a right to get a facility and have their own decision to create what will do with their body. Okay, thank you.
Thank you, Betty. I didn't mean to rush you so fast. I'm going to do a very fast round down the table. Sorry, Hailey? Oh, yes, Dr. Anna. I am so sorry. Thank you for the reminder, Hailey. So just to remind everybody about the question to Dr. Anna, I was asking her what, in her view, are some of the best practices that governments can apply for a rights-based approach to healthcare that reaches every person and includes essential SRHR services. Dr. Anna?
Bem, a gente no Brasil vem trabalhando. Started? Okay. Bem, a gente avançou muito no Brasil, baseado na saúde comunitária de base territorial. E it's not that translating. That's not a problem. But Brazil has advanced a lot, but in consolidating universal health coverage through primary health care and community-based strategies such as the family health strategy that we have there. And I think that the most important thing that we have done in the past 35 years is about work to continue to strengthen our connection with the population and their needs. And so we are structuring local council in every unit, basic health, because we understand that that's the most important. We need to listen to the population that we are going to offer the care, and to offer a quality care that involves all the rights from sexual reproductive rights for the women and our girls, adolescents ones. We need to listen to her. And by listening, we are working to amplify our methods to achieve every choice that our population needs to be able to have in the public system too. And that includes the implants, that implant, the intrauterine dispositives, and another methods that protect by sexual disease too. So in Brazil, we do have advanced to free condoms in every school, free condoms in every unit health, to everybody. It's not just for women or just boys. Everybody can reach them. But we still have a lot of challenges to achieve quality of health for our Negro population, to our indigenous territories, and most of all, we have a lot of homeless people, and we need to achieve them too. So how can I improve our methods, and how can I achieve that population if we have a lot of social problems, not a health only? But we do have some programs and strategies that it's health teams dedicated for that kind of group people, and only do offer for that kind of people in the territories, because if we mixed with central communities in another local health, we think we are gonna I don't know how to say that in English, but I think we are gonna dispute. It's gonna be like a game, who reach first, and it's not about equality. I'm gonna do inequality if I do that. So we really do believe in Brazil that to achieve the universal coverage by primary healthcare, we need to listen to communities, their needs, and then work for them, not only to them, you know. And I think that's all. Thank you.
Thank you, Dr. Anna. And I think that last sentence is a very important reminder for all of us who work in this and other fields, that we need to listen to the people that we are working with and for, and to take those needs into account. I'm going to take a very fast thing through the panel, asking each panelist to answer in more or less one sentence, if you can, the following question, and then I will go to the floor. So each of you, I'm going to start with Haile at the end and come down. The right to health can seem abstract as a framework for concrete action. So from each of you, what would you say is one key practical way that it has been applied or can be applied to your work? Haile?
Accountability is important, and there are mechanisms to measure the accountability of governments. The Universal Periodic Review of the human rights record of the countries is done every 4 or 5 years, and that actually offers a unique opportunity to hold governments accountable for the right to health.
Thank you, Dr. Anna.
I think access to quality healthcare should not be a privilege. It needs to be a right. And for that, so we are working on it. And I think by listening our partnerships, our neighbor countries, we can achieve that.
Thank you.
Again, a very important question. It will remain an abstract concept until and unless people are not at the center of how systems and policies are made, something that you were saying, listening to people. And it is so important. It is important to center the lived realities, the needs, the challenges of those communities at the center. to bring it to life, to understand the nuances. And I really want to emphasize on the power of qualitative data because, when we talk about narratives, when we talked about lived realities, quantitative data is important, but it is abstract and meaningless unless there is qualitative data. Qualitative data, it also helps us in understanding those nuances of how access to health looks like for different people. So, for example, what happens when an unmarried woman in a conservative society is denied access to maternal care, for example, right? Because maternal care in so many communities is also conditional to the marital status, right? What happens when, let's say, a trans woman or a trans person is denied access to health? And what happens when they are given that access to health? It really brings concepts to life, helps us see the impact. Stories and qualitative data also helps us understand the intersectional perspective that we love talking about, right? So, for example, how does access to SRHR look like for a woman versus men, for a woman from a certain socioeconomic strata, for a woman with disability, for a woman from a climate vulnerable community? So, it is so important to center policies, programs, health systems, in the communities and center people's voices there. Yeah.
Thank you very
Yeah. In my work as a journalist, we should put the data to to co- uh, we should put the data to make our reporting is more complete because if when we must recheck again what the government say. When government say everything is clear, we already give education at school and we already decrease child marriage. We cannot just report what government say like that. Even like ministry said, we give the condom free. But as a journalist, we should check it again. Yeah. Yes. So if we not check again, how can we make sure it?
Thank you very much. Thanks to all the panelists. I think those were very good, crisp things. Let me ask first the room and then through our colleagues if from the live stream. Are there any questions from the room to the panelists? Please, Shobana. Well, you're loud enough for us, but I think for the live stream, let's.
I'm Shobha from India, and I have a question for my neighbor, Aisha. In your working, what are the challenges which you face, particularly when you are engaging male people? Even engaging the girls and women is difficult, I believe. So can you enlist some of the challenges which you have been facing and how you are overcoming them? Thank you.
I'm going to just see if there's anybody else in the room, and then I'll come back to the panelists. Kelsey?
Thank you. I'm Kelsey from Geneva. My question, I think, is for everyone, but I'll let you direct it, Madam Moderator. In the current political climate, I want to know, do you still see value in engaging in international collaboration and engaging with multilateral fora like the UN and WHO? Or do you think it's time for everyone to turn inwards and just focus on delivering domestically? Thank you.
Sorry. I opened my mouth immediately and then I remembered that it wasn't being directed to me. Anybody else? And then, yes, please, over there.
Thank you. So my question is to Ms. Aisha. So it's kind of similar question to her. So you told that you hold local governments accountable and you work on changing mindsets of men, enabling them to become allies. But as similar is the case in South Asia, it's difficult. And I'm from Nepal. In case of Nepal also, if we work with local government, if we have this kind of conferences or meetings or anything, they just say that this is a women-centric or women-related thing. So women officials or women should participate. Why do men we have to go? So this kind of mindset is there. So how do you work with these local governments? How do you work with these men to become allies in this kind of situation in order to promote right to health and maternal health?
question.
Good morning, Joe from Trinidad and Tobago. This can be anyone on the panel. I'm listening to everything you said. You spoke about obviously the importance of health equity and accessing women, girls, marginalized communities. What strategies can you reflect on that you believe were the most impactful with shifting policymakers in your particular context?
And I have a question to Betty on the role of the media, which is, do you think that an active engagement with media, be it from government or from an international organization, to basically incentivize the storytelling, the media getting engaged would make a difference in building that kind of narrative into the public? I'm going to start with Dr. Anna, since you had the same sharp reaction I did on Kelsey's very provocative question. And I think also because Haile, you essentially answered it. And then I will come in this direction. Dr. Anna.
Ok. Vou dizer em português e acredito que vá traduzir. Eu sou uma grande entusiasta da multilateralidade nas parcerias, sejam elas privadas, sejam as parcerias com as NGOs, as ONGs. I'm a biggest fan of partnership, mutually and bilaterally, and with private sector and with the public ones. I think when all of these actors are involved, we do achieve what we are putting on an agenda, on the priorities. So we learn a lot with other countries. I'm talking about Brazil. Brazil has reduced the fertility by women to 1.6 now in 2025, but that's not alone. We have worked with Canada, we have worked with Cuba, Mexico, and El Salvador, and we learn about another strategy that is working fine there, and we adapt to Brazil, to our reality. So I do think instead of all the problems that we have with the governments, with the USA, we need to say that out loud. But I do believe that we can do more, we can do best if we are together. So that's why I was shocking, but I know how provocative is that question, and we need to provoke, and we need to put our governments, I am from the government, so another actors to be on these side events, on these kind of events, to learn from our partnership, to learn with our peers, to advance. We have do a lot until now, but we need to do more. We need to do better. And I think we won't be able to do it alone. That's it.
Yeah, so just to respond to the question directly, no, but there should be a change because the status quo is not working. And the status quo was established 80 years ago, and now it's under severe distress that it really requires some resuscitation in any way. And there are so many initiatives and so many ideas going around in the global health. What is the best solution for the fading multilateralism? And I think Saidi is also part of that. And we are working actually with governments, with like-minded governments, really to make sure that this multilateralism, the status quo, really is resuscitated and function to deliver by making the right to health at the center of every response. So that's my response for this question.
Thank you. Thank you very much, Haile. Aisha, and then Betty.
Okay. Yes, okay. So again, around male engagement, men, of course, don't like to listen to women, especially men in the government. They hate listening from young women. So it is very, very challenging to engage men actively to become allies. So again, challenges is that they don't like to listen, right? Access is also an issue, especially when we work with men in the government, right? I would like to share how we do it, right? So we have an initiative called Masculinity Manifesto, which is redefining how masculinities and how allyship looks like. So far, if we see, most male engagement programs have been very passive, have played very safe, have not really challenged the systemic inequities around patriarchy, male privilege, and power, right? Until and unless we don't do that, we will not see a shift in how different genders are right now, right? The power imbalance. So in Masculinity Manifesto, what we do is we identify allies, male allies from within the communities, train them. It's the traditional peer-to-peer education model, but it goes beyond the basics of masculinities. Men like to be center of the attention, so we give them that attention, right? So in those spaces, male facilitators sit with young boys and men and do reflective exercises around how they see patriarchy, of how they see gender inequity, of how patriarchy impacts them, right? And then shift the conversation around male allyship and also bring it into the everyday. Instead of calling them into sessions and conferences and say, we'll teach you how to do male allyship, they become very confrontational, right? Because, of course, it's about the power imbalance. We go to the traditional spaces where young boys and men hang out, which is chai dhabas in South Asia, right? The tea stalls. So how do we make male allyship the new sexy, the new cool, so that, because that's the language younger boys understand, right? So we mostly work with young boys in male engagement, and I think that has worked really well. It's a little more difficult to work with older men, but also important to get their buy-in. We're still trying to crack it.
Sorry, colleagues. We have the honor to be joined by the UN Special Rapporteur on the Right to Health, Dr. Talieng Mofokings. I hope I didn't massacre your name. But if I can invite you to make some remarks, and then we'll come back if time allows. Please, can you join us? Back mic.
Good morning, panelists, dear guests and delegates, and of course, friends and colleagues. You can't hear me? Okay, I must get really close. Good morning, everyone, excellencies, distinguished guests, and the panelists. Thank you very much for this enriching conversation. And I want to thank specifically the Global Center for Health, Diplomacy and Inclusion for convening us in this manner. In my mandate of the right to health, I deal with many, many constituencies who raise many different conversations and challenges with me on the right to health. And so this space that you have created for dialogue and solidarity and shared purpose has really been important and really appreciated. And I think today's insights have contributed in the ways that I will also take the passion forward in my own mandate. And I charge all of us with the same call to action. We have spoken about the right to health, not as an abstract right. Human rights are quite tough sometimes to explain, but I think we've heard how tangible they can be. They are a living commitment to dignity, to justice, to bodily autonomy, and to equity. We have explored what it means to operationalize that right, what it means to build health systems that are accountable, inclusive, gender responsive, and grounded in human rights. Yet, of course, we must acknowledge that challenges remain, some are emerging and new, at a global reality that maybe some of us were not really organized and ready for. As it unfolds across the many regions around the world, anti-rights narratives and regressive policies are gaining ground. But I think we are stronger and we are bolder and we are much more committed to the rights and the human rights agenda. And of course, access to sexual and reproductive health rights are being restricted in ways that we haven't seen before, which is really a restriction on bodily integrity, on bodily autonomy, on choice. And so health and care workers and human rights defenders around the world are being silenced, and evidence-based policy is being replaced by ideology. But there is one thing in this conversation that we have heard. It's the spirit of passion. It's a reaffirmation that we are not powerless or voiceless. So as we leave today, what are the kinds of calls to action that we can take forward as we move? For me, it's that we must stand firm in principle. We must really demand that we recenter those who are often marginalized by policies, by programming, and by many other social, political contexts. We must invest in equity. Resourcing the movement is really, really key. And that investment must be comprehensive, must be multi-year, must be unrestricted, and there must be much, much more than they already are at the moment. And we must ensure that adolescents, LGBTQA+A persons, persons with disabilities, people who are internally mobile or migrants or in, really difficult migratory status are not left behind, because we know that in our own programming, in SRHR, we can truly give people back their dignity. And solidarity, I can't stress this enough. I've spoken about the right to health as an important tool for diplomacy in global health. And so solidarity is really important as we seek to get to equity. That action requires us to collaborate from south to south, south, north, south, in very different ways that maybe we had not even been creative to imagine before. The ways in which we truly have to work outside of the silos. I know we say it, but do we actually do it? And I think we have to think intentionally about how all of our different programs must be speaking to each other across different movements. And so as we think about how to move forward, the right to health and making it operational, making it understood and part of everyday society, it means that ensuring we leave no one's humanity as a negotiable tool. We can no longer negotiate based on each other's human rights, that I will take this contract or this funding, but if I don't support the rights of sex workers, or if I don't support the rights of migrant people, if we have to push back this idea that funding has to be conditional on us choosing ourselves over other human beings as well. It means that maternal health, sexual and reproductive health rights, and of course, universal health coverage, the magic legacy work of the moment, they must not be competing agendas. They are all in one. They are comprehensive. They are all encompassing. And they are part of the same promise of human dignity. They are part of the same promise of human dignity. And so, let us leave here, friends, colleagues, and distinguished delegates, with renewed determination. I have it as a call to action from all of you this morning to make that promise real in our everyday work, in the decisions that we make, in the priorities that we set, in the indicators that we set, and in the ways that we prioritize work and what we see as urgent. And so for every person everywhere, I would like to thank all of you for convening this morning and for bringing us this incredible agenda and manifesto of how we go forward, recentering dignity of all people and using the right to health. Thank you very much.
Thank you very much, Dr. Mofokeng. And I know you had to jump out of another panel to join us, so I really appreciate. Betty, sorry for stopping before I got to you. I pass back to you, and then I'll wrap up.
Sorry. Impact, it doesn't mean the bigger one. Impact, it doesn't mean that time a government no more prohibited abortion for unwanted pregnancy. But as long people in beside you, the society, in people in around you keep speak aloud about when they see injustice in this issue, it means your reporting is already impactful.
Thank you very much, Betty. So what I'm going to do is use Joe's question as kind of my wrap up on what I think are some of the key points. So as a reminder, Joe's question was to the panelists, what would you consider the most impactful advocacy strategies for policy reform in the local context? And I think from everyone you heard, so starting again with Hailey, and we also heard it in the wrap-up comments of the Special Rapporteur, the importance of working with the international laws and rights that have been established. The use of the UPR, the Universal Periodic Review, in the Council on Human Rights as a tool at the national level to hold governments accountable in their reporting to the international community. From Dr. Anna, very much the importance as a national actor, national government actor in the space of not assuming that because you are acting on behalf of government, you come in with the strategies predetermined, that it is not going to land if you do not engage, if you do not listen, and if you do not adapt. You are not there to impose, you are there to hear what the needs are, and then from a government perspective, to adapt your policies and the key importance of political, continued engagement with your communities. For me, Aisha, the importance of organizing, from both Aisha and Betty, the importance of organizing. And I would say, you know, coming back to, and I thank Kelsey for a very important provocative question. I looked around the room. I think I am the only person in this room, I regret to say, old enough to remember what it was like before Rio and Beijing and Cairo. And I think we have all got very comfortable because in the 1990s, the UN was able, the international community was able to establish a set of treaties, conventions, agreements that set the tone for the world in which we have lived in the last 30 years. And so none of you, I think, are old enough to remember when this was not a given. And I was lamenting earlier that I recall when I was speaking to Shobha, when the Women's Caucus in all of these conferences was the most important place to be for information. And government delegations came, and the women, because getting this sense of equity, this sense of everybody is entitled to live in the same world, impacted on the negotiations. Those civil society actors were the most critical in moving this space forward. And as I said, we've become very comfortable, and a lot of that passion seems to have evaporated. And I really thank both Aisha and Betty for reminding us that you are not going to move it if you do not move it with actors. The importance of youth, the importance of media, and to remember that particularly in the media front, the way governments are going these days, it's not a given that you are acting in a safe space, but that information really matters. So I'm going to end on this call, kind of echoing what the Special Rapporteur said, to say, please use this next couple of days to network, to build those coalitions, which are important not just within your national space, but across the space. You give each other strength, you get ideas, and we do need to start moving that international space again, because globally it is constricting. And so we have to refurbish that passion and fight. I mean, Hailey and I actually know each other because across Africa and the Caribbean, we are building this space on the health front, because I think what we all learned in COVID is that the issue of access and equity and rights is not a given. Many of us were the bottom of the list to receive vaccines with a clarity that nobody cared if our populations died because they were not considered important. We need to rebuild those coalitions. So please use the rest of the next couple of days to build those networks, and you will need to lean into each other's strengths. So with that, let me thank all of the panelists and everybody in the room. I'm sorry we did not have time to take from the live stream, but maybe we can find a way to adjust on that down the road. And thank you all. Have a good rest of your day and a very successful 2 days in coming out of this stronger and better engaged. Thank you all.
You want to start? You want to help me? I think in front. Yeah. Thank you. Amazing. Thanks everyone. Please remember,